Good afternoon, everyone. My name is Kristen Willard, and I am the Vice President of Population Health and Care Delivery at the COPD Foundation. On behalf of my colleague Delia Prieto, who is Director of Research, and the entire COPD Foundation, I'd like to thank you for joining us today. This event is part 2 of a 2-part teleconference series and will dig deeper into bronchiectasis and NTM. Now, before we get started, we have just a few housekeeping notes. Today's program will have 2 question and answer sessions, during which you will be given the opportunity to ask questions of our expert speaker. Now, aside from those designated Q&A sessions, your telephone lines will automatically be muted, and that's so we can avoid unnecessary background noise. Our operator will tell you how to pose a question when we start the Q&A sessions. And know that this call is being recorded, and we will let you know where you can access that recording in the coming weeks. Okay, let's get started. We are very excited to have Dr. Tim Axelmed of the Mayo Clinic as our expert speaker today. Dr. Axelmed is a consultant and associate professor in the Pulmonary Disease and Critical Care Medicine Division of the Mayo Clinic in Rochester, Minnesota. He has co-authored a previous international statement by the American Thoracic Society and Infectious Disease Society of America on the diagnosis and treatment of non-tuberculous mycobacterial disease, or NTM, as well as collaborated as an investigator on a number of multi-center clinical trials involving mycobacterial disease and bronchiectasis. Additionally, Dr. Axelmed serves as the director of the Mayo Mycobacterial and Bronchiectasis Clinic, as well as the chair of the Foundation's Bronchiectasis and NTM Research Registry. So we want to thank you again for joining. I'm now going to turn it over to Dr. Axelmed, who will be telling us first about the causes of bronchiectasis and preventing and treating exacerbations.
Thank you, Kristen, and I wanted to also extend a very warm welcome to everybody that was able to join us today. This is an exciting time to participate in non-tuberculous mycobacteria, or NTM, and bronchiectasis. I know that this is a issue that many of you have struggled with for some time. Today, we're going to try to spend some time with a dive into bronchiectasis and NTM, but I would share with you that we could literally devote an hour to each one of the bulleted items, if you will, on the agenda for today. So what our plans are, in the interest of time, is to talk about 15 minutes about bronchiectasis and hit hopefully some of the highlights and drill down a bit more after the first session that was held in January, have some questions and answers about bronchiectasis, and then turn our attention to NTM and comorbidities for another 15 minutes or so, with some additional time at the end for questions in this way. I would share with the group that there will be an opportunity to learn more information and where additional resources are regarding these comments, and so that you'll be able to follow up any questions or concerns you may have. My personal disclosure here is that I'm an advocate, if any of those that we've been together, about education, and I am a strong believer that the more informed you all are as patients and caregivers, the better position you'll be in to understand, one is why things are the way they are, and then what those options are that are in front of us today. In this, I would reassure most of you that this is a very treatable condition. It may not necessarily be curable, but very treatable, and something that with proper attention and information will put you in a position to, I think, adequately address your concerns. So let's turn our attention to bronchiectasis. As many of you know, bronchiectasis involves a scarring, if you will, or of the bronchial tubes rather than the air sacs themselves. With that scarring goes some damage of the small hairs or cilia that line the bronchial tubes, and as a result we have a tendency to retain or have pooling of secretions or mucus that are normally made in the lungs. We oftentimes refer to this pooling and subsequent infections and additional scarring as a vicious cycle. What we would share with you about bronchiectasis is that it's very heterogeneous. That is to say, there are many, many causes. And in most instances, this is there because of no fault of yours. It's not because you've smoked or you've done things or been somewhere or been around secondhand smoke, but it's there by no fault of yours. Because it is a scarring process, it's a chronic process. So this is something that's manageable over time, but will require attention. As a result of the scarring of the bronchial tube, we oftentimes think about the natural history of this made worse by what we call an exacerbation or a flare or increased respiratory symptoms. So when we talk about exacerbations, we're really meaning an acute or a sudden change of symptoms. There was an international panel gathered about a year and a half ago that formally put together a definition of what this type of exacerbation would involve. And it generally involves increases in symptoms that are more than just a few hours, usually lasting a day or two. Those symptoms, as many of you already know, involve increased or a change in cough, increase in the sputum volume or consistency that has become darker or thicker. It may or may not be associated with more shortness of breath or a decrease in your exercise tolerance. Most patients will oftentimes have fatigue or malaise, tiredness with these flares, and that occasionally, in some instances, may be associated with some bleeding, or we call it hemoptysis, or bleeding from the lungs. In most instances, we define this exacerbation understanding that the primary driver is infection is with antibiotics, which brings us to the treatment of exacerbations. Because we think that most exacerbations are driven by an infection, and there's many types of infection, that is, there are bacterial infections, there are fungal infections, there are viral infections, and there are mycobacterial infections. In most instances, when there's a sudden change in symptoms and the sputum turns color and thicker with or without bleeding and fatigue and shortness of breath, as we've talked about, we think about bacterial germs as being the driver. Many of us who take care of bronchiectasis patients will oftentimes try to collect sputum, and that oftentimes will help us understand what germs are present in the airway and may be contributing to the infection or the exacerbation that's present. And I just want to also be clear for everyone that our airways, even when we don't have bronchiectasis, are not sterile. That is to say, there are bacterial and other germs present in our airways at all times. And we talk about a community of germs. And that during these flares, one germ essentially outgrows all the other germs and we think contributes to these increase in symptoms, and that's what we oftentimes focus our antibiotics on. One of those germs that's not uncommon, and anywhere from about a third to a half of individuals with bronchiectasis, is called Pseudomonas, and that is a bacterial germ. The caveat to Pseudomonas is that it only responds to one type of oral antibiotic. It's called a fluoroquinolone. Sometimes we would use ciprofloxacin or cipro, levaquin or levofloxacin, or Avalox or moxifloxacin for the treatment of this Pseudomonas. Part of the problem is that with additional treatments, oftentimes the Pseudomonas will become resistant, in which case we're then relying on IV antibiotics, either given in a hospital setting or in an outpatient setting to treat the Pseudomonas. That's not always present, but also underscores the reason why many of us try to collect sputum to understand what germ or germs may be present so that we can very tightly tailor antibiotics to give the very best treatment with not overshooting or using excess antibiotics and selecting out more resistance when we don't need to. The treatment of exacerbations really depends on the severity of symptoms. Sometimes that requires coming into the hospital to start on IV antibiotics and go home on either oral or more IV antibiotics. Or sometimes we can treat this as an outpatient with an oral antibiotic. So that really depends on how your course has been, and then your interactions with your providers and physicians that are looking after you for the treatment of bronchiectasis. So again, treatment of exacerbations almost always requires antibiotics, and that oftentimes will take some time to get better, but are clearly treatable. We try to minimize the number of exacerbations. We understand that individuals that have more exacerbations have more symptoms, have accelerated loss of lung function, and worse quality of life outcomes. So trying to minimize or prevent exacerbations becomes increasingly important. As I had mentioned, we think that one of the primary driving forces of exacerbations is this pooling or retention of secretions in the airways. And so our primary goal, if you will, is to mobilize or prevent the pooling or retention of secretions. And there's a spectrum of options from some very simple activities to some very complicated activities that may help facilitate that. I would also preference this and just share and try to reassure all of you as patients and caregivers that what works for one patient will not necessarily work for another patient, and in most instances requires individualized care and assessment. So try not to be too discouraged if you talk with someone or a peer or a colleague and find out, gee, this was the best thing that came along and had a very good response, and you tried this and it doesn't work. That's our rule rather than the exception. But it is worthwhile trying to prevent these exacerbations, and we talk about airway clearance, that is, prevention of this pooling or retention of secretions. There are some simple, easy things to do. So in most instances, I ask patients to be active. And that level of activity helps mobilize those secretions. It's less important exactly what that activity is, but most patients walk. In the wintertime here in Minnesota, for sure, which generally would be somewhere inside rather than out, but being active is important. And to couple that then to other wellness issues from a women's health or a men's health issue, being active is great for your bones. Muscle strength, balance, cardiovascular, great stress management. So keeping active and moving is an essential element of any airway clearance program and management program for bronchiectasis. The next step is something called the Pep Device, or positive expiratory pressure devices. Some of you will know this by flutter valve, acapella valve, or now an Arabica valve, or and to work with your providers, with the respiratory therapists, with the nurses. And again, the idea here is it is something that you blow against. It's not the incentive spirometer that you would get after surgery, but it's something that you blow against, sends vibrations into the lungs and loosens up secretions. It doesn't work in all patients. And so in those patients that do have a good response, we could use it once or 100 times a day. Most people use it once or twice. If it doesn't respond, then we look for other ways to potentially mobilize secretion. So again, this is a trial and error basis. The next thing oftentimes is controlled cough, sometimes positional therapy. Some of you may recognize something called a huff cough, trying to then use these techniques. This is something that's oftentimes emphasized in some of the activities like Tai Chi or yoga, which again are great activities to do to try to mobilize secretions. The next step is a little bit more involved yet, with something called nebulized hypertonic saline, and that involves concentrated salt solution. Our body's concentration is about 0.9% salt, and that the concentrated is 3%. So it's over 3 times the concentration, and the idea is to use this with a nebulizer, usually once or twice a day, starting in 3% or sometimes even 7%, which is what's used in children with cystic fibrosis, to try to bring moisture into the airways, loosen those secretions up, and make that easier to expectorate or cough out to, again, prevent pooling or retention of secretions as part of this airway clearance strategy. And then lastly is something called a Percussion Vest. And there are several products on the market, and this is designed to put on during this time of trying to mobilize secretions, airway clearance, oftentimes used twice a day as a starting place, sometimes less, sometimes more. And that can be coupled to using nebulized hypertonic saline or other techniques like the Arabica valve to try to come up with a program to minimize the amount of time required to do this, yet to gain the most benefit. Some patients, using a vest, for example, may be too much discomfort to the chest wall, especially in patients that are a little bit older. But again, there's not a right or a wrong way to approach this. It's an individualized basis, and I would encourage patients and care providers to work with your physicians to find out what works best for you. Sometimes we need to do a little bit more during these exacerbations, and sometimes we then do this during a maintenance, but all the time. Oftentimes, participation in a pulmonary rehab program will help guide you and give additional information to understand and help you with sorting out what works and what doesn't. And of course, then general lung health, making sure that you're up to date on your vaccines, will be as important as well. So there are many things that we can do as far as this bronchiectasis, even though we may not have a reason for this to occur, that will help treat this. It may not make this go away, but it is treatable and manageable. And what I tell patients is that I think it's important that you engage in life and find those things that bring meaning, and that we, with these kinds of treatment regimens, will then allow you to participate in those activities. With that, I think I'm going to stop here, and then I'm going to turn this back over to my colleague, Kristen, and let's talk a little bit about questions before we move on to discussing NTM.
That's excellent. Thank you so much, Dr. Axmet. We would now like to open the lines for questions in order to allow as many people as possible to pose a question to Dr. Axmet. We ask that each caller limit themselves to one question. Please also recognize that we are unable to provide specific medical advice to callers. So with that, Stephanie, let's open the phone queue.
Sure. To ask an audio question, you may press star followed by the number 1 on your telephone keypad. Your first question comes from Mary Miller.
Hi there, doctor. When you were talking, you mentioned 1/3 to 1/2 of those with bronchiectasis have Pseudomonas.
Correct.
Was that only if infection symptoms are present, or isn't that everybody with bronchiectasis?
Yeah. So, Mary, that's an excellent question, and I would share with you that there are really two groups of bronchiectasis patients. One are children with cystic fibrosis, which we're not talking about today, and then secondly, adults with bronchiectasis that we call non-CF bronchiectasis or NCF bronchiectasis. What we understand is when the scarring or dilation of the bronchial tubes of bronchiectasis first forms, and oftentimes it's idiopathic, the Pseudomonas isn't there, but over a period of time, this community of organisms that's in our airway select out, if you will, to allow this Pseudomonas to show up. So when we as physicians see Pseudomonas in the sputum, that already gets our attention and tells us that the Pseudomonas has been there probably for some time and can affect adults as much as children with bronchiectasis. And that's the one that is about 1/3 or about 40% of the time, depending on which series one looks at. And that's true for our U.S. bronchiectasis registry as well as registries in other areas of the world. I hope I've answered your question.
Well, my doctor said I have mild bronchiectasis along with that. Is this something that the sputum culture would normally register?
Yes. So another great question about the severity of bronchiectasis. That is to say, not everyone has severe. There is a spectrum from very mild bronchiectasis picked up incidentally, really without any symptoms at all, to individuals that do produce a fair amount of sputum every day, and then everyone in between. So in most instances, we would still want to sample generally with just a spontaneous sputum, and really the intensity of how much we collect or how we approach this really depends on, one, the severity of your bronchiectasis, which is assessed by your symptoms, how you feel, the pulmonary function test, whether there's loss of lung function, and what the x-ray looks like. And that as the severity or the extent of bronchiectasis worsens, we're really compelled to try to minimize the number of exacerbations, which have a tendency to increase the worse the bronchiectasis is. So if there's mild bronchiectasis, it may be with general lung health intervention that it'll remain stable for many years to come. Sometimes it'll progress, but that's where the follow-up on an individualized basis becomes increasingly important.
Very good. And then that Pseudomonas that's also picked up in just a regular culture?
Correct.
Culture? Okay.
Correct.
Great.
And there are instances for the group that many of you maybe have undergone what they call bronchoscopy, where generally done by a pulmonary doctor, looks down into the airway with a lighted scope. We generally reserve that for individuals that are unable to produce sputum on their own and have a situation either because of symptoms, x-ray, breathing tests, some other reason that we're very concerned that we need to make an assessment at that time. So not everybody with bronchiectasis needs a bronchoscopy, but in very select instances, it can be a very effective diagnostic tool to do a sampling, say, if one is unable to cough sputum up.
Okay. Thank you.
Your next question is from Ann Dix.
Hello, doctor. I appreciate the opportunity. I would like for you mentioned in the treatment with antibiotics, there were some antibiotics, and I didn't catch the one that began with an F.
I'm not sure that began with an S.
No, F is in Frank.
Frank. It's the name of a category or a family of antibiotics called fluoroquinolones, or just quinolones. And the three that are most commonly used in North America, in the U.S., would be the ciprofloxacin or Cipro, the levaquin or levofloxacin, and Avaloxin, moxifloxacin. And that whether that's an appropriate antibiotic or not really depends on, again, whether there's Pseudomonas or not, whether it's sensitive or not, and then also understanding that every antibiotic, like most medications, has some risks to it. And so we have to be mindful of, is it worth giving a course of antibiotics and a sufficient course of antibiotics worth the risks? And in many instances, certainly for individuals with bronchiectasis, the benefit to be gained outweighs the risks. But like any medicine, there are risks associated, and those are things I think that are important that you learn about, that you talk to your physicians and providers about, and understand. Again, the more you understand about what we're trying to accomplish, risks and benefits, I think the better position we'll all be in. And as Ann asked this question, I would also share, just as an observation, as many of you are aware, that bronchiectasis and NTM are really affect more women than men, certainly in North America. And again, I can't emphasize enough, by no fault of yours, not because you smoked, not because of secondhand smoke, not because of things that you've done, but it's just a susceptibility. There's a great deal of research ongoing trying to sort out why that's occurred. We don't have all the answers yet, but there's great intensity in the investigations trying to sort that out.
Thank you. Would you recommend that  patients have an antibiotic on hand for an exacerbation?
Yeah. So again, that depends really on the patient in the sense of how often those exacerbations, what the germs are that are present in sputum, even collected during times when there's not an exacerbation, to understand, again, this balance, if you will, of using antibiotics when necessary and then antibiotics when there is an exacerbation or infection. So some patients find that very helpful to have a course of antibiotic on hand based on their past experience and organisms in their sputum, and other patients it may or may not be necessary. So again, without trying to be vague, it really is dependent upon the patient and what the experience has been. But many of my patients do have some antibiotic available should that need arise.
Thank you.
Stephanie, I think we have time for one more question.
Your next question is from Diane Mariani.
Yes, hi, thank you. I wanted to know if you could comment on the use of guaifenesin, 1,200 milligrams, to help mobilize secretions.
Yes. That's a great question, and it has to do with guaifenesin, or for those that aren't familiar with that name, Mucinex. It's the active ingredient in Robitussin. It comes in tablets. You can get it over the counter, usually 600 milligram tablets. The biggest downside is a very large tablet, sometimes hard to swallow because of its size. The usual dose is up to 1,200 milligrams or 2 tablets twice a day. Much like the Pep valves, that Mucinex works in some patients, but not everyone. And unlike many of the other medicines we use, including antibiotics, the Mucinex really doesn't interfere with other medicines. It doesn't cause side effects and is generally very well tolerated. There are other areas, and that's considered a mucolytic, something to loosen up the secretions to contribute to this airway program. So it is something to try. It generally is relatively inexpensive. It's fairly safe relative to other risks and other medicines that we use. And I personally encourage patients, if they want to try that, and this holds true for secretions, whether it's in the sinuses or in the lower airways, to try it. And if you find that it helps, it generally does not interfere, have drug-drug interactions or problems like many of the other medicines we have. This also brings up the notion, I probably should emphasize, that being hydrated is also important, and it becomes increasingly hard for many of my patients to have an adequate amount of fluid intake, water intake, over the period of a day. And so very often I would encourage patients to put out a container of water at the beginning of the day so you can keep track, but make sure that you stay well hydrated, because that will help facilitate loosening up secretions as well. Obviously, you don't want to drink all that right before bedtime or you lay down, because that generally only happen once or twice. But to have that adequate water intake through the period of a day and avoid being dehydrated.
Thank you.
Thank you so much. And just to callers who are in the queue, don't worry. We're going to have another Q&A segment after Dr. Axman's next part of the presentation. So, Dr. Axman, I'll turn it back over to you.
That's great. And again, thank you very much. So let's shift gears a little bit and talk now about non-tuberculous mycobacteria and comorbidities. As I mentioned before, one of the drivers we think for bronchiectasis is recurrent infection. One of the infections is something called non-tuberculous mycobacteria. So I had mentioned that there's different groups of organisms. There's bacteria like the Pseudomonas or staph, Haemophilus, some that you've heard. There's viruses like the flu, like a cold. There's fungal infections or molds that can cause. And then there's a group of organisms yet separate called mycobacteria. The probably most notorious is tuberculosis. And the NTM are non-tuberculous mycobacteria, so you are not contagious. You do not, repeat, do not, and repeat, do not have tuberculosis. And unlike tuberculosis, these mycobacteria are present everywhere in our environment. We call them environmental pathogens. They're ubiquitous, that is, they're everywhere. They're in every town, they're in every city, they're in every state. They're on every continent of this planet. And in fact, of the mycobacteria, and there's probably 150 or almost 200 now different species, Mycobacterium avium complex is the most common worldwide. There are increases in the environment, usually in soil or water sources, and in the U.S., North America is in the south and southeast part of the U.S., and then our hotspot in the U.S. is Hawaii, and that presumably is in part because of temperature and humidity conditions. Having said that, those of us that take care of NTM patients see patients from all over the country and all over North America and the world. I see people from Alaska and Canada. Here in Minnesota, we have a great deal of NTM, and so it's not just restricted or just limited to the south and southeast part of the U.S. When it comes to these sets of infections, like the bacteria, very often we need to establish whether there is or isn't NTM present. And that, again, comes down to relying on either sputum samples or, in some instances, bronchoscopy samples to understand what germs are or are not present. In most instances, when these NTM germs cause problems, it generally will be in the sputum and it will stay in the sputum. So we collect multiple sputums and oftentimes see this present in multiple sputums. Sometimes, because these are germs everywhere in our environment, if it shows up and there's not a problem, there's not symptoms, there's not radiographic changes or progression, that there aren't other changes, say, on pulmonary function tests, because it's there, it may be there because it's everywhere in our environment and not causing problems. But when it is there and causing problems, generally symptoms that are very similar and overlap with bronchiectasis, with fatigue, with cough, with sputum, with or without chest pains or coughing up some blood, then we need to treat these mycobacterium. It's important to realize that the NTM are a subgroup of the bronchiectasis. That is to say, almost all patients with NTM have bronchiectasis, but not everybody with bronchiectasis has mycobacterium. We think that adults that don't have cystic fibrosis get their NTM at the same time that they develop their bronchiectasis in many instances. There are other instances where patients will have bronchiectasis first and then go on to get NTM. The best example to illustrate that is in children that have cystic fibrosis. Oftentimes they have advanced bronchiectasis even before they're age 10 or 12, and they have the staph and Haemophilus and Pseudomonas, but they don't get their NTM or MAC, this Mycobacterium avium complex, till their 20s or 30s. So in some instances, the MAC or NTM comes after the bronchiectasis, and in many, especially in our adults, will come together. The number of times that we look for NTM and find it is generally about a third to a half of individuals with bronchiectasis. In our adult research registry, we had about 64% that either had a history of an NTM or at some point isolated an NTM. So it comes down to, much like we talked about before, that in patients with bronchiectasis, we do collect sputum, and generally in groups of 2 or 3, and as many as possible, but usually 3 is a starting point, to look specifically for these mycobacteria, which require a different type of test than trying to find bacteria. The importance here is that if these NTM are found, that may be in addition to or in place of bacteria in the airways. The problem with the mycobacteria to a large extent is it's more difficult to treat. And specifically what that means is it generally involves a number of medications for a long period of time. If we take the example of the most common form of non-tuberculous mycobacterium, MAC, MAC, Mycobacterium avium complex, we generally start out with 3 antibiotics for about 18 months, 18 months, rather than a 10 or 14 or 21-day course of antibiotics like we would give for many bacterial infections. So it becomes increasingly important to know whether it is or isn't present. To help put this in perspective, when we do cultures for bacteria, the bacteria, when present, usually grow in the lab in about 2 working days or 2 days, and then gives us so very quickly. The MAC cultures will take up to 6 weeks, or in some instances 60 days to come back. So again, we have this by almost 30 times as much, rather than 2 days, 60 days, and that's one of the reasons why when we do need to treat these NTM infections, it requires a long course of treatment, and our antibiotics are less effective. There continues to be an ongoing intense amount of work looking at newer, more effective antibiotics, but this is oftentimes a challenging situation. And what I share with patients is that this is clearly treatable. It may not be curable, and curable in the sense that because we get exposed to this in our environment all the time. That is to say, tuberculosis or other pathogens aren't around us all the time, but the NTM are. So again, very treatable, but not necessarily curable. When we do treat the NTM, depending on the severity, somewhere between 60 and 90% of the time, we can make that germ, the MAC or the NTM, go away in the sputum, and that probably at least half or 2/3 of the time it stays away, which means that 1/3 or 1/2 of the time it can come back, or a cousin of it can come back. So that, and again, by no fault of the individual, we understand that left untreated, the problem is that sometimes this will progress. One of the conundrums, if you have, is that it's hard at the beginning and when the diagnosis is made to know whether this is going to be something to progress quickly, whether it'll sit dormant for a period of time, or how best to approach this. So very often this requires longitudinal assessment, that is, serial appointments over a period of a few months or a year or two to sort out, are things getting worse? And if they are, our hand is tied and we need to think about treatment. So as much as a MAC is the most common, 3 antibiotics, sometimes we can give those every day, sometimes we can give those 3 times a week. If it's more advanced, sometimes we give the antibiotics every day plus an IV antibiotic or an inhaled antibiotic. The Mycobacterium abscessus, which is a cousin of MAC and probably the second most type of NTM, oftentimes requires IV antibiotics at the front end. And that's more than just a few days or a week or two, and many months followed by oral medicines. So this becomes a complicated situation, but again, very treatable to approach this. And we want to always, as in many instances, make sure we don't make a situation worse rather than better. So when we choose which antibiotics to use, it's important that they're chosen to give the best chance for success, yet minimize a risk of making a complicated problem even worse. There have been several studies out in the last few years suggesting that oftentimes we try, in the spirit of being practical, simple but simpler but less intense regimens, which have a tendency to just make the situation worse rather than better. I would also share with you that in addition to these NTM, we also have what we call comorbid issues or other medical problems. That is, there are a couple areas in particular outside the lungs that also drive symptoms that are confused with whether it's bronchiectasis or the NTM. Specifically, reflux, gastroesophageal reflux, GERD, acid problems are not uncommon in many patients with these problems, and left untreated when it's present can oftentimes be the driving force of exacerbations or more symptoms and needs to be treated in itself. And what I share with patients oftentimes is if that is in fact driving some of the symptoms, I can give you medicines by the carload for the NTM or the bronchiectasis, and we won't get on top of the symptoms until these other issues, if present, are treated. And so again, if there's some reflux present, should be treated. Akin to this is sinus disease. Many patients with bronchiectasis, for a number of reasons, will also have chronic sinus infections. If there are active sinus infections present, it'll be increasingly difficult to get on top of symptoms without having that taken care of fully. And then there are other sometimes comorbid issues overlap with things like emphysema in other patients who have smoked or done or had other exposures. And again, my point is that when I think about patients that come and they have bronchiectasis or NTM, we should be vigilant and exhaustive about taking care of both of those, but also understand it's not just about what's going on in the lungs, and we have to be mindful whether or not there's other contributing factors. And with that, I will also then come to the bullet, if you will, on the agenda about researchers' involvement. As I've mentioned, this is an exciting time. There's probably been more work and interest in bronchiectasis and NTM by patients, by investigators, by caregivers, by even pharmaceutical industries in the past 10 years than probably the past 50 or 100 years combined. So I would encourage everyone, again, as mentioned, that the more information you have about these conditions, if that's something that you're wrestling with, puts you in the best positions. And a way to kind of share resources, which we'll have links as the staff will share with you in a moment. There are 2 conferences coming up for patients later this year, one in May. That'll be prior to our American Thoracic Society conference in California in the San Diego area. And then there'll be another sponsored by Non-Tuberculous Mycobacteria Information and Research. And there's another conference that will be for patients at the end of a World Bronchiectasis Congress, which will be held in Washington, D.C. in July. It'll be July 14th. It's a Saturday. The Congress is being organized by Dr. Ann O'Donnell, who's Chief of Pulmonary at Georgetown University, and there will be a session dedicated just for patients on Saturday afternoon. There will be more information and resources shared with a follow-up that the staff will arrange for everyone, and that if there's any interest, please make yourself known, and we're always looking for additional support and resources to advance the science so that we can then share that with patients and hopefully improve the natural history of these 2 what are otherwise sometimes challenging problems. With that, I am going to stop once again, and I'll be glad to try to answer some additional questions.
Thank you so much, Dr. Axman. So, Stephanie, let's open the phone queue. We have just over 10 minutes for questions, so we'll hope to fit as many callers in as possible.
As a reminder, to ask a question, you may press star 1 on your telephone keypad. Your first question comes from Catherine Shander.
Hi. I live in New Hampshire, and I have bronchiectasis and MAC. I was first diagnosed in 2008. I had a lingulectomy, went to National Jewish Hospital, got some good treatment. I was okay for a while, and then the MAC came back in 2017. And so this is my second round with MAC, and I'm being treated with 3 antibiotics and an inhaled antibiotic. My question is, can you discuss the benefits of perhaps living near the ocean to help with bronchiectasis and MAC?
Yeah. So, Catherine, that's a great question about how much does environment play here, and that's a great question that I wish I had a solid and a complete answer for you. And the answer is, I don't know. As best we know from epidemiologic studies that we have, living closer to the ocean doesn't help or harm NTM development. And we understand, as mentioned, that these MAC are everywhere in our environment. There is soil, water, so we think about sinks, faucets, showers, that sort of thing, trying to sometimes make changes to minimize that exposure. But even doing all of that, we understand that there's not a clear association. There has been data and by some investigator groups that certain activities like certain gardening, certain types of showering may have an impact, but that other studies have not been able to show any connection with what you have. So sometimes there can be a connection and sometimes not. There's not clear information that making a mitigation or a intervention will minimize the risk of reinfection just because it is so ubiquitous. So your course, as I understand it, with having been treated successfully once, having a period of time and have that come back is not uncommon and can occur, as I say, and up to 50 or 60% of individuals, and again, by no fault of yours. Two things that I would probably follow up with is that when patients first get their NTM treated and it goes away in the sputum with or without, as in your case, having surgery for limited disease, as was done, oftentimes the chest x-ray and the CT scan, not oftentimes, almost always or always, the x-ray won't be completely normal. And I caution patients just to be mindful of that, so that unlike many of the other infections that we treat in the lungs, there will be always some residual effect. So, for example, if someone comes to me and has just a regular pneumonia, bacterial pneumonia, I give them antibiotics, and they had an abnormal chest x-ray, that goes away completely. That never, it's not there in the future. By x-ray, CT scan, it's gone completely. MAC and bronchiectasis are not like that. So even with treatment, there may be improvement. Left untreated, there's sometimes waxing and waning, coming and going of abnormalities, but it won't be normal completely. So that adds to this difficulty sometimes of when do we need to treat, and that really is dependent on this longitudinal or the serial clinic appointments. The other part of this is, as mentioned, we don't want to make a situation worse, and I would be remiss not to mention that if the decision is made not to treat, say, MAC, it's present, we also don't want to lose or develop resistance to certain antibiotics, so it becomes increasingly important not to use antibiotics like azithromycin or clarithromycin alone if we're not treating the MAC, because then if and when that time comes, as in your case, we need to treat again, that becomes something that it's not responsive to and makes things very complicated. So very often, if MAC is present or other NTMs, and we decide for whatever reason to watch this, not forget about it, but watch it, see what happens, see if we're going to need to treat down the line, is to avoid the macrolides, that is azithromycin or Z-Pax, or Biaxin or clarithromycin for treatment of other infections. There are many, many other antibiotics that can be chosen for treatment of infections associated with bronchiectasis. In some instances, we think about using azithromycin for preventing exacerbations for what we call inflammatory purposes, but that's something we need to be very cautious to make sure that NTM is not present before we think about that. So I hope I am able to answer some of your question.
Thank you. I do have a quick follow-up, though. I think my major problem is my bronchiectasis, and there has been a study of cystic fibrosis patients who were also surfers that the study found that breathing in the salt air helped to thin and loosen up the mucus. That's just one study, of course. But then also it's generally said that being near the ocean helps you to take in more oxygen because of some ionization process. So that's what I'm wondering. Not necessarily living at the ocean, but because I have the opportunity, I'm near the ocean in New Hampshire, would walking every day at the ocean, help with my breathing and help with loosening up my phlegm?
Yeah. So, Catherine, again, great questions. And the easy part of my response is walking every day for sure will, I think, improve your lung health. But I would tell you that whether you were here in Minnesota as well. So the point here is that being active and having a airway clearance program based on regular aerobic activity, being well hydrated, trying these other maneuvers with or without the Arabica valve, with or without hypertonic saline. Those sorts of things are probably more beneficial. I'm not aware that the iron type of data coming off from the coast is compelling enough to help or guide that patients should move to a certain area, say, hey, we should all go to the coast type of thing. I think that I have many patients who, when they're near the coast, actually are just more physically active, and as a result then probably have better control of their bronchiectasis. So it's a great idea, but oftentimes that's based on just being more active when you're near the coast. The other question that is often asked is, should I move from somewhere that's somewhere drier, say to the southwest, to Arizona or somewhere where it's drier, and will that help? And again, this is because of the ubiquitous nature of this. Sometimes that's a benefit and sometimes not. And so I'm hesitant to recommend for patients to sell their house, leave their job, pick up their family and move and not necessarily gain that benefit. So I can't wholeheartedly endorse moving to the ocean. It sounds beautiful. And I think I can endorse, though, being active, whether it's at the ocean or at home.
Thank you.
Your next question is from Laura Kelly.
Hey, I would be very curious if you know anything about the nitric oxide studies that are going on. I've read a little bit about it. I'm very intrigued since it's not a drug. It's a natural element. Do you have any opinions or do you have any knowledge about it? Thank you.
Sure, and just for everyone's information, as mentioned, there is a great deal of interest and intensity and investigation trying to find better approaches to the treatment of NTM, and that one of the early observations was a nitric oxide, which is a naturally occurring substance, can have an immune modulating process and may help patients in some instances deal better with infections. I would really caution that this is a very preliminary set of data. There are a couple of very early trials going on in the U.S. using specific nitric oxide at various doses, trying to establish whether or not it adds something to what is already observed. And again, the notion of nitric oxide is it may help facilitate the body dealing with infections, not just NTM. But there are ongoing trials, nothing ready for prime time yet, but there's interest and certainly a need, as many of you have experienced firsthand, for better, less toxic, and shorter treatment regimens, but not ready for prime time yet.
Got it. All right. Thank you.
Your next question is from Carol Legmans.
Yes, thank you. My question was in regards to the first session when it was Dr. stated that the aerobica, those devices don't always help. I do have mild bronchiectasis. I have what they call kind of dry. I don't produce a lot of sputum. But I was told that even though it doesn't make me cough up a lot, to go ahead and continue it. Do you think that's a good idea?
Yeah, so again, that's a great question, Carol. And so, again, my response would be it depends. I think that for patients that have what they, as you mentioned, dry bronchiectasis, who really don't cough up much sputum, the question is there sputum there that needs to come up, or do you have one of those forms? And it doesn't happen often, but it certainly occurs where we have this scarring, this dilation of the bronchial tubes without a lot of mucus retention. So if over a period of time it looks like there's just not a lot of mucus that needs to come up, I don't know that the Arabica valve or any of the other interventions in itself will likely alter the natural course of that. So would I rather have you put your energy and time into other wellness issues of being active and concentrating on women's health issues? I encourage my patients to spend the time and effort in what we think is going to be of most benefit to you. And so in that situation, I would continue to, again, focus your attention in that way on things that will benefit you from a women's health issue as well as your bronchiectasis.
Okay, so just general exercise, hard breathing exercise, those kind of things.
Yep. And whether that's walking, yoga, tai chi, on elliptical, inside, outside, bicycling, rowing, the exercise, swimming, it becomes less important than just being active. And again, thinking about all those other benefits to gain as well.
Okay. All righty. Thank you very much.
I want to say thank you, Dr. Axmet, for the excellent presentation on behalf of the Foundation. We really hope that everyone has found this town hall teleconference helpful. So I'm sure there are many, many questions out there. If you still have those unanswered questions, we encourage you to sign on to Bronch and NTM 360 Social. We want you to post your questions in the questions and answers section. So Bronch and NTM 360 Social, if you don't know, is our free online community, and it serves as an excellent resource for patients and caregivers. And you can access that by visiting www.bronch-and-ntm360social.org. So one more time, I'll say it, www.bronch-and-ntm360social.org. Now, within the next week, everyone on the phone can expect to receive a follow-up email from us at the COPD Foundation. And don't worry if you missed something or you want to learn more about the topics that we've covered today. You'll see that the follow-up email will include information about helpful resources, as well as information about the conferences that Dr. Axmet referenced. You'll also see that there will be a link to a survey, which will allow you to provide us with feedback on this event. So we'd like to say thank you again so much for joining us today. Thank you to Dr. Axmet for your time and this excellent presentation, and have a great afternoon, everyone.